Yes, we're good. Thank you.
Okay, great. So this work it's a journey. So which started with doing research on heart failure in pregnant and postpartum women in India to now leading to working on a software platform in order to make echocardiography available for everyone in especially in low resource and outpatient settings. So it's a perfect example of a north south to north collaboration and how we have learned what we worked on in a low and middle income country to now using it to make a change that or and to sort of make a technology available to all countries globally so that people all around the world can have access to a life-changing cardiac ultrasound. Okay, so that's the short introduction to this work. So coming straight to the background, as I mentioned, it started with our work in India. So we all know that cardiac complications are the leading cause of indirect maternal deaths globally, and also the most important cause in the UK. The incidence of heart failure in pregnant and postpartum women in India in our study hospitals from our own work is around 2 per 1,000, which is not a very high incidence rate. But if you look at case fatality, almost half of all the women who present with heart failure in our study hospitals die within hours of reaching the hospital. We looked at the history of these women. None of them had any cardiology assessment or any scanning of their heart before they presented with heart failure, and unfortunately, a lot of them went on to having a fatal heart failure within hours. So we know that echocardiography is really essential for diagnosing maternal cardiac complications for timely management and preventing deaths. So when we started our work, our research, we thought that we will use the reports from echocardiography that is done routinely, or at least for these very severely ill women from the hospitals where we were doing our study. But what was very clear, and very soon we realized that there were no echocardiography facilities in these hospitals. And that led to the realization of a much larger problem in several resource limited settings in India and also around the country, and which is shortage of cardiologists. And there is just one per 30,000 population, and India is a huge country. So we were then thinking of how, first, of course, we were thinking of our research as to how do we enable scanning of the heart? How do we know what is going on with the heart in these women where we were, because a research without looking at the heart, without scanning the heart, is not going to give us any information in order to prevent or make a difference into saving the lives of women who were turning up with heart failure. So we looked at focused cardiac ultrasound as a potential solution. So this is not anything new. This protocol basically has been there and has been used, especially in high-income countries in emergency settings for a very long time. And this is recommended where in settings where standard echocardiography is not available. So, by definition, this is a very simple ultrasound. It's goal directed, simplified. It's a qualitative examination. It's mainly based on a dichotomic gross abnormality, whether an abnormality is present or absent, and can be performed by physicians in charge of patient. Now, this was considered very basic and very kind of very straightforward, and mostly if there, as the definition says, you could only pick up gross abnormalities. But with newer machines, with handheld machines, there is a lot more advancement in this technology, in this protocol. We can pick up even milder problems, and that is what we have seen in our work. So we were also lucky at that point when we were starting this study, which was around the end of 2018 and beginning of 2019, because Philips was launching their new product, a new handheld ultrasound machine, and that was called Philips Lumify. So we thought that we could try this and we should be training the obstetricians. Another advantage for us is that obstetricians are aware of ultrasound. They do conduct ultrasound of the abdomen, a majority of them in the settings where we work. So we thought that they could be trained to acquire images using focus, which can then be interpreted remotely by experts. And also the advantage of Lumify was that you could upload the images and onto a cloud server. So we started with thinking that, of course, we have to use this. We can use this protocol, we can modify it, we can perhaps use it, but we need to also demonstrate that this works. And at that point, we were mainly thinking of our research as to how we can make it as robust as possible. And alongside the heart failure work that we were doing, we could also validate that the approach that we were using and this modified focus protocol that we were using training obstetricians is really working and it's fit for purpose. So our first objective was to determine whether focus performed by trained obstetricians and which were then the images then interpreted remotely by experts can identify cardiac abnormalities. We also then wanted to examine the agreement between experts independently reading the images to assess reliability of the interpretation protocols, which we also adapted and developed. So this work, the research, of course, was undertaken through the Maternal and Perinatal Health Research Collaboration India. So this is a collaboration of 16 hospitals across 6 states in India, which I established in September 2018. So heart failure research was undertaken in 10 of these hospitals. And we also did the focus validation work in those hospitals. Since then, since 2018, we have done a lot of work using our platform, and it has created a unique database of clinical, biochemical, and imaging data. At the moment, we have data from more than 15,000 mothers and infants from multiple studies. So moving on to the methodology, it was a straightforward four-step methodology, and we called it MA3 Focus at that point. So what the four steps were: first, we train obstetricians to conduct echocardiography using a low-cost point-of-care ultrasound machine. So even though Philips Lumify was a new product, it was still about a tenth of the cost of a card-based standard transthoracic echocardiography ultrasound machine. So it was quite cheap. And then we decided to use a simple image acquisition protocol. The second step was for the images to be uploaded onto a cloud-based server. The third step was to then those images to be interpreted remotely by experts. And we had two experts, one based in India and one at CCRF at Oxford. And then the diagnosis was provided on a simple form with image quality interpretation. So using these four steps and using this protocol, we were able to train. And this is just a picture of the protocol that we used. We, of course, as I said, it's not a new methodology. We adapted a protocol called FATE, and then we optimized it as well for our population. For example, we couldn't use the subcostal view because when a woman is pregnant, it's very difficult to assess and capture anything that is between which is in the subcostal region between the abdomen and the sternum, the lower end of the sternum. So we captured three standard 2D views, two-dimensional views, and four color flow views. We then had to work with the protocol. So as I said, there are a limited number of views. So what happens in a standard transthoracic cardiac ultrasound is that the cardiologist or the expert kind of looks at the heart from many different angles. If they find an abnormality, then they can switch and look at another view. But this is not something that we could do because these were non-experts. We could only train them to do only those 7 views. So we had to come up with a protocol in a way that it could assess the images to come up with understanding the structural and the functional problems with the heart. In addition, we also had to develop an image quality assessment protocol. And this was to kind of look at whether the images were of good quality, medium, or poor. Initially, we used this to give regular feedback to the obstetricians in the first 1 month or so, and then later on, we have been using this protocol to kind of assess whether the images are of standard quality. So in the beginning, we trained around 22 obstetricians from 10 hospitals who were provided training to use hands-on training to use image acquisition to acquire the images using Philips Lumify. You can see on the picture, this is Dr. Saswati Sanyal Chaudhary. So she's now a master trainer. And since we have started this work, she has now gone on to train more than 36 clinicians who are not just obstetricians. So the validation work, it was again a very simple validation exercise, but we followed the international recommendation for validating anything that is related to focus ultrasound. As I mentioned, focus has been used, but it was the first time that this was used by obstetricians. So we needed to validate and see whether the images that were acquired were of good quality. And secondly, we had to look at the inter-rater agreement between experts using the research protocol. And thirdly, we also had to look at the diagnostic accuracy. So we had around 301 women in this study, which was nested within the ongoing case control study for heart failure in pregnant and postpartum women. There were 172 suspected cases of heart failure, 129 controls. What we did is that in 109 patients, independently, the two experts, one in India and Oxford, they were reading these images and assessing and filling the forms, which we then compared to see what was the agreement, and they were using our protocol that we had developed. In terms of diagnostic accuracy, it is recommended that at least a small portion of these focus images are compared with the standard thoracic ultrasound. So what we did is that in 36 patients, they were scanned both using our focus protocol and the handheld machine, as well as a transthoracic echocardiography was done. So what we found is that multifocus can be used in low resource obstetric setting. Obstetricians can be trained to acquire high quality images with portable cardiac ultrasound, and images can be interpreted remotely by experts using our image interpretation protocol, which was really good for us. But more importantly, we saw that there was substantial agreement on the cardiac parameters between the two experts reading it, ranging from around 94% for left ventricular ejection fraction to almost 100% for valvular disease. It was not looking back at that, it's not very difficult because the complications are so overt. You can see it. There's less likely that somebody would not see the problem, the structural or the functional issue with the heart. Again, the agreement on the diagnosis was 78% between the focus and the standard echo. The where we lost or where the agreement was lower was in the left ventricular ejection fraction, and that was because of a lag period between the focus ultrasound and the standard ultrasound. So what was happening is that when women came with symptoms of heart failure, we were able to scan them using focus and handheld machines within 12 to 24 hours, but then they had to be kept on a waiting list to go on the standard echocardiography. And that sort of created a little time lag in which either the patient improved or had even a worse outcome. So that led to a change in the function of the heart, which was the left ventricular ejection fraction. Again, most of the views were graded as good quality. What we found was the apical four-chamber view. Until date, this is the most problematic view, and this is only because it's very difficult to put in women who are especially heavily pregnant towards the third trimester or end of third trimester, the breasts are engorged and the abdomen is also quite distended. So it's very difficult to find the apex of the heart. So this is, and then when you find it, it's quite difficult to position the women in a way that we want to capture this view. So first starting with the impact on the heart failure research that we have been doing. So we have been using this protocol along with this telemedicine approach since February 2019. And we have till date recruited and scanned more than 600 suspected heart failure cases and two times the number of controls. This is, of course, one of the largest studies and perhaps the only study that has been collecting echocardiography images from pregnant and postpartum women. So first starting with the history. So this is what was reported in the as history of cardiac problems in the suspected cases. So when these women came, you could see that 91% of the women did not report any cardiac problems or any pre-existing problems with their heart. But when we scanned their heart, almost 72% of these women were found to have an abnormality, and which was also very significant. The most common abnormality that we are finding is pericardial effusion, and almost 81% is moderate to large effusion, followed by mitral valve regurgitation, so which is a valvular abnormality. Then there's an enlargement that we are seeing of the left atrium, a chamber of the heart. Rheumatic heart disease valves were found in 13% of the suspected cases. Then there's right atrial enlargement, and then various different grading of the left ventricular ejection fraction. So I would like to draw your attention to rheumatic heart valves. So if you look at the pie chart, you will see that only 6% of these women reported that they had a history of rheumatic heart disease. But when we scan these women using our protocol and the handheld machine, more than twice, that is 13% of these women were found to have a rheumatic heart valve. And that is not the only thing. What we found is that 25% of the control, so women who were recruited because they did not present with any heart problems or did not have a history of heart problems, were also found to have an abnormality, a structural abnormality with their heart. And this was significant abnormality in around two-thirds of these controls. So now thinking of clinical translation. So of course, we have been using this in research and we really wanted to see what we can do in terms of clinical translation. As I mentioned previously, there is a shortage of cardiologists. We don't have echocardiography facilities. So we didn't just want to complete the research and do nothing about it. And we were also very much inspired by this editorial. So when we published our paper, when we submitted our paper, it was published in JES, the Journal of American Journal of Ultrasound. And this one, and there was an editorial written by Kimuru et al. On our paper. And basically, this was the inspiration for us to then think, why are we not thinking of clinical translation? Because what they said is democratization of ultrasound is the future, considering ease of access, low cost, and the proliferation of telemedicine. And although Matri focus is a small step, it may reveal the path to the one holding the probe in the future. So since then, there have been other editorials, like, for example, this one, and we were initially thinking, so this is again another turning point in our thinking of clinical translation. We were thinking that our approach and what we were doing is mainly applicable for low resource settings, but this was an editorial written on a paper that was looking at heart failure rates in the rural areas in the United States. And what they found was that if people were not getting ultrasound or people were not being investigated soon enough, and that was leading to a high rates of heart failure. And they, in their editorial, suggested that matrifocus that we had developed in India could be one of the ways in which people or suspected cases or cardiac patients could be scanned in outpatient settings who can then be referred for further investigation and treatment. So these were the two inspirations that we had. So then we started our work. So reminding you of the four steps that we have. The first step is most important is to train the non-experts. So we have been training people from CCRF, from Professor Paul Leeson's team, have been going to India and training, but this is not something that you can do all the time. So we had to come up with a solution for this first. And the first solution was that we create a training resource. This work was funded by Medical Research Foundation. We have created an animation where we are showing how you can acquire the images of the heart. We also took some time in the beginning of the animation to create awareness about cardiac problems in pregnancy and how not to ignore women who might present with breathlessness, thinking that, oh, basically this is anemia or this is pregnancy symptoms as well. So this training resource is available for free for anyone to use. It can be used to train non-experts and also to reinforce and do refresher trainings. We found that refresher trainings and reinforcements were quite important in order to improve the quality of imaging. But then if you think of steps 2, 3, and 4, there was a problem. And this became very clear when we started talking to some of the cardiologists. I remember talking to a cardiologist from Namibia. So she is the only one in the region, in a very large region of Namibia. And she was saying, oh, please, please do not train non-experts. If they start scanning and sending me all the images, I will not be able to read them. And I will not be able to even look after the patients that I already have. Can you imagine how many scans will come to me? Plus, there is no internet. You might not even be able to upload the images. So this what then it came. It was very clear that you don't solve the problem because there's still a shortage of cardiologists. So you can't do steps 2, 3, and 4 very quickly or readily. So we had to come up with something, an assistant that is going to automate the other 3 steps. So we started working on developing AI models for automated labeling of the views, quality grading, and pathology. We were learning along the way that because there is no model for handheld ultrasound or focus ultrasound, so it was even starting to understand how do we label the views was quite interesting. So we completed this work about 2 years ago, and since then we have been working, and our goal is to develop an AI-powered focus solution software platform that will automatically read these, label the views, grade their quality, and then detect pathology from the views that are acquired by non-experts. So, as I mentioned, the resource is available, and I would request everyone to have a look at the training video. So, now moving on to how we are going to, so this is the part where we come from a local work to globalization, or a work that was done in a low income setting to how it is now being translated to have an effect globally. So, giving you again some numbers here, and that is we know that 500 million people have cardiovascular diseases and around 64 million have heart failure each year. There is a rise in premature deaths from heart failure, despite 80% of these being preventable. And of course, these deaths are disproportionately higher in low and middle income country settings. And the main problem is the delay in case finding and diagnosis. And this is what we have seen in our work, and this is what has been pointed out again and again from several countries around the world. We know that echocardiography is the first line of diagnosis for cardiac pathology. This is also most readily available, very low risk, um, but still, around, not everybody is getting this. We know that there is no limited echocardiography facilities in low resource hospitals. It's very costly, and there are shortage of experts. In our work, we've seen women dying within hours of reaching the hospital. And according to the British Heart Foundation, 40% of suspected heart failure patients could benefit from an early assessment. So, what we have been doing is working, and now we're using our model to create AI focused solutions for screening and triage. So this solution will enable assessment of cardiac problems in real time by a non-cardiologist in outpatient settings using any handheld device. It is a state-of-the-art AI-powered tool to assist clinical decision making within existing clinical pathways, which is very important, and it will either uh, give an notification to escalate care or to follow the usual pathway. Therefore, the risk is quite low. Ultimately, the goal is to help triage patients for right diagnosis and treatment at the right place and at the right time. As one of our PPI members pointed out, she said that this could reduce waiting times, doctors' time, avoid unnecessary referral and worries for patients. Our technology is quite novel. There is no such AI-powered software platform for heart assessment. We have the competitive advantage because of the unparalleled image, the focus image bank that we have created in India as part of our ongoing heart failure in pregnancy work. We have completed our proof of concept work, which and developing high performing models. As I said, the risk is low in terms of getting future regulatory approvals because it will either escalate care or it will just follow the usual care, however long it takes. Our team is again highly diverse. I'm being helped by Bartek, who is an engineer and AI expert at the BDI. Of course, Paul Leeson has been engaged in this for quite a while. He's a cardiologist, and Sarah Bourne, who is our commercial lead and a health tech expert. Finally, just to tell you and a statement on our goal and what we basically want is to develop a software platform that uses state-of-the-art multimodal AI algorithms to generate critical information from simple focus scans and merge that with clinical history to then assess the cardiac problems in real time by a non-cardiologist in an outpatient clinic, which will then guide the triage and referral of decisions for patients to get the right diagnosis and treatment at the right time. I would like to thank all the study participants, all our funders. This work is now further funded by a Rose Trees Trust Fellowship. So we are hoping to move on to doing further R&D for this work, and ultimately hoping to spin out the technology to commercialize it. And finally, I would like to leave you with this slide, thinking about globalization to localization. What are the challenges and opportunities? Because we live in a connected world. Therefore, work that we do in any part of the world can lead to benefits for people globally. Okay, so thank you for listening, and I'm happy to take your questions.
Great. Thank you so much, Manisha. Let's pass it over to Eris, and then thank you everyone for putting questions in the chat. Please keep putting them in the chat, and we'll have time at the end for for questions and discussion. So over to you, Eris.
Thank you so much. So we're going to move from the mother to the baby and also talk about ultrasound. And what I wanted to talk a little bit about is how AI can help in fetal ultrasound in underserved regions. I'm Iris Papageorgiou, and I'm a professor at the Nuffield Department of Women's and Reproductive Health. I carry a number of grants from different bodies and charities. But relevant to this talk, I co-founded a spin-out from Oxford called Intelligent Ultrasound, which was a company that was engaged in creating AI solutions for fetal ultrasound. And that company has now become part of GE. I've also founded a couple of other companies through my career, and I received travel expenses. I'm editor-in-chief for the British Journal of OBGYN, so if you have good papers by conflict of interest, I love to see them. And I also work a part of my time for the WHO as chair of the Technical Advisory Group for Maternal and Perinatal Health. So just back to my research work. So a lot of my research work happens in underserved regions. And by underserved regions, I mean regions where maternal and neonatal morbidity and mortality are highest. And my work really is maternal, perinatal, and neonatal health. And a lot of these settings, as part of trying to establish outcomes for pregnant women, we tried to implement over the last 15, almost 20 years, ultrasound screening in many settings where ultrasound is just not available. And that's kind of led us on this pathway to try to see if we can automate certain aspects of ultrasound. And that's really what I'll be talking mostly about today. And that desire to bring ultrasound to underserved regions is not just our desire. If you look at the WHO recommends that all women should have an ultrasound scan before 24 weeks. And the reason such an ultrasound is recommended is to check fetal cardiac activity, count the number of babies, check if there's a multiple pregnancy, what the chronicity is, look at gestational age and fetal size, and do a basic anatomical check, as well as placental appearance and placental location. In particular, one of the crucial factors here is gestational age, and estimating gestational age is really important for the care of a woman. Everything you do in obstetrics in terms of antenatal care depends on how pregnant a woman is. And quite often women don't know how advanced their pregnancy is because they may not have regular periods because of malnutrition or anemia, or they may have just don't remember it. And because they don't have access to early ultrasound, gestational age is often not known. Now, apart from the importance of gestational age at the level of the individual woman, it's also really important when you're trying to gather data from lots of studies. And I showed you the map where we work, and we've worked over the years on observational studies, cohort studies, randomized trials of nutritional supplementation, vitamin D. We've looked into home pollution as determinants of growth or how they affect growth. We've looked at various medications and randomized trials. All of these things require us to know what the rates of preterm birth are and what the rates of small for gestational age are. And it's really important to remember that gestational age is such a crucial determinant. So, as I say, not just at the level of the individual woman, but also at the level of trying to gather data. So, if you think about the most crude way of phenotyping babies at birth is to say, well, the baby is of normal birth weight or of low, not low birth weight with a cutoff of 2.5 kilograms, and that's kind of regardless of gestational age. But the moment you have gestational age, you can make this a little bit more granular. You can say, well, you've got a normal birth weight baby that's not preterm, or low birth weight baby that is preterm over here based on a gestational age cutoff of 37 weeks. So over 37 weeks is not preterm, below 37 weeks is preterm, and then dividing it by the birth weight again and 2.5 kilogram cutoff. But also, of course, once you know gestational age, you can become more granular because babies grow over time. So a baby that's of low birth weight could be preterm, or it could be just small for gestational age, or it could be both. So you can then start thinking about more granular phenotypes still. So SGA babies on the right-hand side here that are not premature, SGA babies that are both small and preterm in this little quadrant. Then you've got appropriately grown for gestational age babies, and then you even have large babies that may be term or preterm. So having gestational age is such a crucial determinant of categorizing your population and understanding the burden of disease within a population. It's estimated that in about 40% of births on the last sort of global data, we don't really know accurately the preterm birth rates because we just don't know the gestational age of pregnant women because they don't have access to ultrasound. So why is it? What is difficult? And this was a nice review from several years ago, and it's still current today. They identified two sets of barriers. On the left, they identified equipment barriers. So there's a lack of equipment. Equipment is expensive. When it's affordable, ultrasound machines may malfunction in the field, and there's no ultrasound maintenance capability often in remote settings. And on the right-hand side is the barrier of a lack of trained staff and a lack of training opportunities. Now, to be fair to the manufacturers, one of the barriers, the left side barriers, are starting to become lessened. Manisha already mentioned Philips Lumify, but there's a number of manufacturers now that make lower cost point of care devices that are very suitable for point of care use and are also a lot cheaper, such as GE, Butterfly, Content, and there's a whole bunch of others which we reviewed in a recent paper if you're interested. But the problem of people doing the scan still remains. And of course, as you know, we need scalable training programs and we need people to be trained in those training programs. But the reality of the matter is that it's very slow. So the question I posed several years ago, and we've been working in this field now for a long time, is could we use AI in trying to fast track, if you like, that training program and fast track the understanding that we have. And I just wanted to cover three broad areas. And the first of these is how does AI work in trying to understand what images look like? And I just quickly talk you through how a computer learns what an image looks like, right? And in the simplest way to think about this is to think about how we teach kids to recognize images. So if you wanted to teach your kid what a cat looks like, you rarely say to your child, a cat is an animal with round eyes, a triangular nose, whiskers, and pointy ears. Usually, the way you teach a kid what a cat is you see a cat, you point at it, and you say, that's a cat. And then you see another one, and you say, that's a cat. And what the children do is they learn very quickly the patterns and they recognize what cats are, even when the cat might be hiding its face, or even when it sees it from behind, or even when the cat is halfway in a box, your children will be pretty good at recognizing the cat in the box, even though large parts of it are obscured. What you're doing there is you're labeling data, okay? You're labeling data with a name. You're saying this is a cat. That's the label. And you're using big data. You're using lots of examples of images of cats. And what the children are doing is they're learning, and they're transfer learning as well. So they're transferring the knowledge from one image to the other, so that even if they see a cartoon cat, they'll be really good at recognizing it pretty quickly. And computers learn in very, very similar ways. You start with big data. Here in this example, we're using images of cats and dogs. And these are supervised. This is a supervised learning approach, supervised because the images are labeled. And what you do is you run these through a number of convoluted neural networks, for lack of a, just for convenience sake, different layers that recognize certain features, certain textures, certain parts of objects. Parts of objects are important for the cat in the box problem. Okay. And what the computer then does is it classifies that object and says, based on the experience of having seen all these many examples, I think this is what this image is. Okay. So in a sense, computers learn very, very similarly to your 2-year-old or 3-year-old child when they recognize images based on large data sets. And once you've done the learning, you then lock the algorithm. Okay, normal learning is taking part, so computationally it's much less heavy. And you show the computer a brand new image, a new image of a cat in this instance, one that it's never seen before. It's not in the training set, so it's a completely new cat. And based on what it has learned from the previous examples, it will give you an output. In this case, it's successful in that output. That isn't always successful. So this kind of model of learning is what is used in, for example, self-driving cars and many other examples that you're aware of that are available day to day. And in this example here, this is just an AI algorithm walking down the street and doing a couple of things. So there's two things happening here. The first thing is something called segmentation, and it's happening in real time. So it's instant segmentation. So segmentation means drawing around the outline of an object. Okay, it's drawing around the outline of a pedestrian or of a car so it doesn't bump into it. Right? So that's segmenting the object of interest. And the second thing, it's automatically recognizing the object. So it's saying this is a pedestrian, this is a bicycle, this is a car, this is a truck. The question we have then is, could we use some of these principles of AI learning of natural images in ultrasound images? And this is the second subject of the talk, which is AI then in ultrasound imaging. So here we have a really simple protocol, and this was a project that we run with the THSTI in India, where we did what we call computer-assisted low-cost point-of-care ultrasound in pregnancy. And we developed this protocol by which you did some simple sweeps of the maternal abdomen and gathered some images, and those images were then underwent, if you like, machine learning. But the importance of the pathway of the probe will become evident in a minute. So let's just start with this top left one. So we're going to see now a little video of someone doing an ultrasound scan, and they're pointing the ultrasound probe at the bottom of the maternal pelvis over the symphysis pubis, going up to the top of the abdomen, and then moving the probe in a T-shaped fashion to the maternal right and then to the maternal left. And superimposed on that video is what we saw before, which is instant labeling. So there's maternal bladder, the fetal head, amniotic fluid, the spine, the placenta, the back. So what the computer is doing here, again, is labeling the object that it's interested in. And it's doing a segmentation. It's doing a much more rough segmentation than on that previous example I showed you. This is just a bounding box around the object. But it's, reasonable segmentation. So it's identifying those different structures in that video. Now, you might ask me, well, Iris, what is this particularly useful for, given that it's just labeling the images. Well, because you know the pathway of that ultrasound, because you've linked the video with the protocol of how the image is acquired, what you saw on that image was that the head, for example, of the baby was the first thing you saw. That means that the baby is head down. The placenta was the last thing you saw. That means the placenta is high. And indeed, you can use this model to detect breech, for example. So this is using the image analysis together with the pathway of the probe in order to look geographically at where the head is in A. You can see in panel A, the bright green line is the fetal head. You can see in the bottom example that occurs to the left of the timeline. On the top example, it occurs to the right of the timeline. That means the head is seen late. And using this methodology, you can detect breech with a very high degree of accuracy. In this study of 330 babies, where about half were breech and about half were cephalic from India and in the UK, we detected 97% of breech babies. And in addition to that, you can then look at the babies where there was a failure in order to try and understand that. And interestingly enough, there were, for example, some babies that were transverse. There was a case where there was a uterine fibroid sitting in the lower segment that looked, possibly like a head. So the mistakes are even explainable as well. So we're using some of these basic principles for very basic ultrasound in areas where there's a lack of ultrasound for basic obstetric care. So it's really important. The aim here is not to replace good ultrasound with really basic ultrasound. The intention is to replace no ultrasound at all with something. And our aims are at the moment to estimate gestation, twins, viability, determine when the baby's head down or head up in later gestation also placental location, growth, and amniotic fluid. So some things are relevant earlier in pregnancy, such as gestational age, twins, and viability. Some things are only relevant in late gestation, such as malpresentation and placental location, growth, and fluid, and some throughout, such as viability. This was another project that we ran. We ran this project in Kenya, the Gambia, and Mozambique, where we had a very basic and quite cheap ultrasound probe made by a Chinese manufacturer, connected wirelessly with also a very low-cost Android app. And the idea here was that the midwife or the nurse would place the ultrasound probe over the head of the baby and move the probe gently up and down, and the machine would automatically measure the head circumference and the transcerebellar diameter in order to be able to measure that automatically and thereby estimate gestational age. It was implemented as part of a study called PRECISE. And again, going back to the previous point, the idea here was to be able to phenotype preterm babies and SGA babies, because we needed to know what the outcomes were in these pregnancies. But also, in addition to that, this was a study of collecting biomarkers during pregnancy. And of course, a lot of liquid biomarkers change with gestational age. So unless you're able to anchor them, it's difficult to know exactly where they are. And this is a system here, and in white is the transcerebellar diameter quality score, and in the bottom line is the head circumference. And essentially, this is the background, if you like. Sitting at the back of this is a system that highlights when the quality of the image is sufficient for measurement. And you can see from the image quality that this is a low-cost device, and therefore the image quality is not brilliant. But one of the effects of this tracer device at a population level is displayed in this graph. And I'll talk you through this. So on the x-axis here, we have gestational age at birth, okay? So going from 25 weeks all the way to 40 plus weeks. And each woman is represented twice on this graph. She's represented in green in the clinical estimation of gestational age, and she's also displayed in pink in the tracer estimation of gestational age. I hope that makes sense. So these are the same women in pink and in green. And what you can see is a distribution of gestational age in green based on clinical estimates, and that's a mixture of fundal height, mostly inaccurate LMP or other clinical information in the absence of ultrasound, because ultrasound is not available in this setting. What you can see in pink is that you have this much tighter or more precise, if you like, gestational age distribution. The mode or the median is not actually that different, around 39 to 40 weeks. But what you can see is that there's an apparent lower preterm birth rate when you actually estimate gestational age accurately. And in fact, the preterm birth rate here, less than 37 weeks, went down from about 16% to just under 8%, with doing nothing, right? We haven't intervened, we haven't done anything. All we're doing is comparing two methods of gestational age assessment. And what we're finding is that the true preterm birth rate in this population is actually a lot less than first assumed. Interestingly, a similar reduction in post-mature pregnancy, which is also important. We did a qualitative study of this and also qualitative studies of other tools. And we asked women and their family members who thought this was useful, particularly in women with uncertain menstrual period. Nurses and midwife liked it because it was easily implemented and they found it very valuable, this information. And they also found that it boosted their confidence and gave them positive image in their community. We also talked to healthcare management, and they were a little bit more concerned about the fact that it's implementable, but that it would increase the workload given the limited staff. And they suggested targeted rather than universal use, which is something that we need to think about when we try to implement some of these tools. We need to take healthcare managers, we need to take nurses, midwives, and families with us. But at the same time, you know, having a system that healthcare managers say that should be targeted is probably not that useful in this setting, given that we're trying to estimate gestational age adequately. Now, one of the things that I've shown you so far and is we're using AI to really help us with what we already do, right? We already check for breach. We already use the ultrasound to measure things, and we're using the AI to help us detect planes, such as the head circumference or the TCD. But I want to just introduce a third concept, which is using ultrasound as a radiomic marker, as a biomarker discovery. Here, what we're doing is we're seeing if the computer can recognize patterns that are not necessarily easy to see with the naked eye. Let me just talk you through this. We've talked about supervised learning, where we've got labeled data of cats and dogs, right? But what if you had unsupervised data? We just had data, and we asked the system to cluster these data into what they look like. So that might look something like this. If you ran these data through a computer algorithm, you might say, well, there's a whole bunch of data that are over here that look like this, and a bunch of data over here that look like this. So these yellow dots are mostly looking like so, and the purple dots are mostly looking like that. Okay, and then there's this sort of intermediate data that are uncertain, where the computer's not sure which category they fall into, and I'm not sure I'm sure which category that animal fits into. But what this allows us to do is to start thinking about, can we use really weakly supervised methods to gather data? And again, I'm going to give you the example of gestational age assessment. So here, this is how we usually estimate gestational age late in pregnancy, by measuring the baby. Okay, and we assume that the baby is an average size when we estimate gestational age late in pregnancy. And that has three problems. One is misclassification. So if you have a small baby, it will appear to be earlier in gestation. If you have a big baby, it will appear to be later in gestation. The second issue is inaccuracy, in that the limits of agreement or the limits of normality are very wide. In other words, if you had a baby that had a head circumference of 310 millimeters, it could be anything from a big-ish baby at 32 weeks to a smallish baby at 39 weeks and everything in between. And we always assume that it's an average sized baby, but that's illogical. And this is the third issue. It's illogical because it ignores biological variation. So the question I posed to the team was based a little bit on these kind of fun apps where you take a picture and it estimates your age. And my question was, could we just estimate the age of the baby, not based on measurement, but just on what things look like? And if you're an experienced ultrasound specialist, you would be able to tell me which one of these is 19 weeks and which one was 33 weeks. I don't know how many of you do ultrasound, but I can tell you that the image on the left is 19 weeks and the image on the right is 33 weeks. And that's because the brain on the left is very simple. It has very simple architecture. It's smooth around the edges. You can see no gyrations here. The Sylvian fissure is very shallow. Whereas here, at 33 weeks, you see gyrations and sulcations. The brain is much more complex, okay? Just based on the image alone, I can tell you which is which. But if you showed me a picture of 19 weeks and another one of 20 weeks, I probably wouldn't be able to tell you because they look too similar. They're too close together in gestation. But maybe if I had a computer brain, I was able to remember thousands and thousands of images, maybe I could. So this is what we did. We took 300,000 images from over 4,000 women where we knew exactly the gestational age. And we trained an algorithm to estimate the gestational age, not based on any measurement at all, but purely on the image appearance on the ultrasound scan. And we then validated that in a completely different data set of just under 100,000 images from 2,000 different women. And this is what you find. So on the x-axis here, we have the true accurate gestational age. And we know it's true and accurate because it was based on validated LMP with an early 12-week scan. So we have a 12-week scan which anchored the gestational age. We add to the time elapsed to the scan that has then occurred. And on the y-axis, we have the estimation based on the AI algorithm. And what you can see is a really good concordance. And you can see this paper in Nature Digital Medicine, where we have all the details and how it stands up in small babies and in big babies and all the rest. We've extended this concept now to a product with our collaboration with industry. And this is just a video that I'm going to show you now. So on here on the top left is the actual gestational age, 12 weeks and 5 days. And what you can see here is that the system has estimated the gestational age based just purely on that little video, okay? It's saying it's 12 weeks and 4 days, and it's giving you also a confidence interval between 12 and 1 and 13 weeks. Let me just show you another example. This is a little bit not as good an image, 12 weeks and 2 days. And you can see here again, the system takes a few seconds to estimate the gestational age, and it works later gestation 2. This is the actual gestational age, 22 weeks. It starts at 20 weeks and 4 days, and after a few minutes of ultrasound scanning, you can see that it moves. It's a little bit unstable at the beginning until it stabilizes around 21 plus 5, I think, 21 plus 6. So you can see how this system then is really useful in terms of estimating the dates of the baby with some really simple ultrasound protocols. And we're using this system now in Uganda, in Rwanda, and part of a nutritional supplementation study, and in 54 sites in Africa as part of a Gates-funded study into preeclampsia prevention. So this is the team in Uganda scanning with a system. This is a cart-based system, but we have it now on a handheld system as well. So you can see just some basic sweeps of the ultrasound machine, guided by this little cartoon. You can see the pie chart on the right, which tells you how far you are on. I'll just fast forward this a little bit. It gets to eventually we'll get to 99%, etc. And give you the gestational age there, 21 weeks and 2 days. And I can tell you that the accuracy data of these are very good indeed at the moment. So this is where we are. I want to complete this wish list for NI-enabled ultrasound because I think ultrasound, we always have to remember, is a diagnostic modality. And unless it's embedded into clinical decision-making, it's only partially useful, okay? I like to think of ultrasound a little bit like a hemoglobin level. Measuring hemoglobin alone is not going to prevent anemia or improve anemia in a population. You've got to link your hemoglobin level with an intervention, right? Iron supplementation, malaria prophylaxis, or hookworm eradication, or whatever. In the same way, ultrasound alone is a diagnostic modality. Just having the ultrasound itself is not going to prevent deaths from placenta previa unless you embed it into a whole system that manages that clinically robust information. It's got to be easy to obtain with minimum training, but it must be integrated with clinical and imaging information. So in summary, then, I think AI and ultrasound has really made pretty remarkable progress. As I said earlier, we've been in this business for a long time, and we started with IA, image analysis, and moved to AI, which is artificial intelligence. And we're kind of pleased that everyone's getting into it now because it is an exciting field. It is really good at ultrasound image pattern recognition, often as good as humans. And in some instances, like we saw in the gestational age estimation, maybe better. Automated recognition and measurement can be currently used for basic ultrasound. And we saw the example of imaging biomarker discovery using AI with the example of gestational age estimation. But you could use image biomarker discovery for a whole bunch of other indications, as we also saw from Manisha's talk. There's lots of other applications. We haven't talked about quality control during screening, which is a major interest of ours, and diagnosis of fetal conditions, which we're currently undertaking. We've been working on wearable ultrasound. There's a whole bunch of work on trust, explainability, and interpretability, data synthesis, digital twins, and large language models. But I've left some things out, so hopefully I might get another invitation from you next time. So thank you very much for that. I just wanted to close very briefly with one final slide, which is this one here, which has been, for me as an academic, a bit of a journey and an interesting one. And it talks a little bit to what Manisha was talking about. You know, when you do stuff within the university and you make discoveries within the university, you've got to work ultimately with industry in order to make those discoveries clinically applicable. So, you know, a university department isn't set up to support 54 ultrasound machines in Africa with a quality control system, with a call center that's available 24 hours if the machine doesn't switch on. So you've got to work with a company. We founded this company, Intelligent Ultrasound. It's now been taken over by GE Healthcare. And for me, it's been a really interesting journey going through that, you know, research to commercialization to implementation pathway that I think would have been impossible for us to achieve just within the university. And if anyone wants to have a chat about this journey, you know, really happy to link up with you guys. So thank you very much for your attention, and look forward to the discussion.